Hello, everybody. Welcome to another edition of the AFR EMS Case Studies. My name is Chris Ortiz. I'm the EMS Division Chief for Albuquerque Fire Rescue. And today we're joined by our Medical Director, Dr. Kim Pruitt.
Hi, Chief.
Welcome, Doc. And we're also joined by Lieutenant Kyle Stevenson.
Hey, thanks for having me. Yeah.
I appreciate you coming out to talk about this case. So today we're going to talk preeclampsia. You were assigned to Rescue 4, and it sounds like you all were dispatched out to a 24 Delta for an imminent delivery. Obviously, very low frequency, high acuity event. Talk with us a little bit, like we ask all of our guests. What are you thinking en route to that call? What are you and your partner going over before you get there?
Yeah, it's the guys on the engine joke with me on this, but every time we've had these calls, I run into the bay and say, hey, this is a basic call, basic skill, right? It just gets kind of, everyone's nervous when that tone goes off about these calls. So to kind of break the ice of like, we can do this, you know. But yeah, once we're in the truck, won't mention the address, but it's really close to our station. So just in the area, we don't have much time to really talk about it. But due to our being down there and where we're going, it's likely that maybe we don't have a lot of prenatal care. Maybe there's unknown influences that the individual's going through, whatever. But we're just thinking like, all right, if we see anything, we're going to stay and play. And if not, let's make a decision if we're going to transport and get it going. Because luckily at Fords, we are close to all the facilities, so we can make those quick decisions.
Yeah, no, that's great. And we typically try to keep addresses out, but we're talking about a local shelter, and it's for folks experiencing homelessness. This shelter, is it specific to females only, or is it?
No, it's where they can go and get food daily. At this time of day, it's very active, and a lot of people, which kind of plays into our, again, like, we don't want to be. If this is a public call, we got a lot of things going on, a lot of people around, a lot of potential scene security stuff, which kind of plays into our initial arriving.
Absolutely, yeah. I think we've all identified areas where they are really public facing. There's a lot of people around. These congregate settings, these congregate shelters, it's difficult to do a good solid assessment. So those are all good things to think through for sure. So that is a nuance to the call. So you're thinking about that. Did you guys have any scene security issues, or were you able to make patient contact pretty quickly?
We did. Luckily, when we pulled up, 5-5 was right behind us in the engine. And so they were out at the gate. We were able to meet the patient right away. The patient was accompanied with a male, and he was saying he was her husband and all that, and they were both pretty worried, and she was holding her belly. And right away, they asked if he could ride in as we were putting her on the gurney in 5-5. And 5-5 said, we're not going to be able to let you come in the back of the ambulance with us. And right away, he got very aggressive and started to make an issue on scene. And luckily, normally with that, when 5-5's there, I'm canceling the engine and letting them go, and they don't need to be a part of this. But I'm glad I didn't, because I was able to tell Kevin Kinney, the officer, hey, like, talk to him, like, let him know, like, if this is a delivery and I want him to be a part of his kid's birth, and we'll get him a ride. Either the rescue will take him in, or we'll figure out something. So Kevin was able to kind of de-escalate him, and he ended up getting a friend to take him. But there was a lot going on in that initial response, and how quick his anger and like aggression got on us. So I actually just put the patient in with Likens was my driver, and he popped in and started doing vitals with the 5-5 medic, and we kind of managed the scene out there. So I really didn't know much about the patient besides that she was pregnant until that was kind of handled outside.
Yeah. Always a special nuance to the case. That happens pretty regularly, where you say, oh, I'm riding with you. We've had instances like both with us and Albuquerque Ambulance where initially we may not allow a rider, but always keeping it patient-centered, right? Is like, there's a lot going on in the back, especially if there's an imminent delivery, that we can't have additional people. Right. But then you guys took the extra step to know that, hey, this is Dad. He wants to be there in that moment. So that was really cool of you guys to honor that, and how quickly just being nice could just de-escalate the situation.
Yeah. And Kevin, everyone knows Kevin. He can bring down the temperature real quick. So it was nice. Again, normally I would have canceled them. So it was just, there's a reason we didn't. And it was nice to have that support. And they didn't really have much to do with patient care, but his care was what they got to attend to.
Yeah, love to hear that. Cool, man. All right, so now we'll fast forward to we get the patient in the back of the truck. She obviously probably looks very pregnant. Your assessment at that point, how far along was she, and what signs did you see of how close she was to delivering?
Yeah, she said that she had been receiving prenatal care and vitamins and all that, but she wasn't able to tell us if she was 8 months pregnant or 9 months pregnant. So changes a couple different things. But she said her water didn't break. She's had no discharge. She just kept complaining of this lower abdominal cramping. So are these contractions, or not able to decipher? But she didn't have any vaginal discharge, and so we kind of moved away a little bit from the intimate delivery. And then after the vitals, we noticed that she was also pretty hypertensive.
Okay. How hypertensive do you recall?
Oh, 172 over 100.
172 over 100. Okay, that is hypertensive. Doc, talk with us a little bit about, from your perspective, obviously we want to identify first, is this an imminent delivery? Sounds like the crew did a great job to recognize, okay, we have a little bit of time, let's slow down. Vital signs are vital, especially in these pregnant patients. A reading like that, 172 over 100, what should be going through our head as soon as we hear that with a pregnant patient?
Yeah, so I think these guys recognized it as well, but you always worry about preeclampsia or eclampsia in a pregnant female, especially more towards delivery after 20 weeks with a blood pressure like that. That's incredibly high for her, and probably more than just pain. I don't know how painful those contractions or the cramping seem to be for her, but that's a little higher than just pain would cause, I would think. I think you did a really good job. I like your chart was excellent in terms of like the questions that you asked, the things you evaluated for. You knew she wasn't delivering right then, so you had a little bit of time to prepare yourself, finding out how far along she is. So am I going to be delivering a preemie, or is this a full-term baby? Did the water break, or is there bleeding or discharge? That would also suggest imminency. And then any prenatal care, I always ask, is the head down? Because you want to know if you're going to be delivering breech or a normal vertex delivery. But you nailed all those questions, got her history, and then recognized the vitals, and I think could go from there in terms of your line of thinking for treatment, for further assessment and treatment.
How prevalent is preeclampsia in pregnant patients?
So it can be up to 5% of pregnancies, and the associated mortality is really, really high. So it's important for us to recognize, especially for folks that are a little higher risk and probably haven't had, monthly ultrasounds and prenatal care. It can lead to strokes, to death, either fetal death or maternal death. Terrible bleeding can complicate the delivery a lot with postpartum hemorrhage. It's a very dangerous disease, and I think what makes it so dangerous is that it's easy to miss, because I think as a culture we get used to seeing people kind of living with high blood pressures, and we don't necessarily always associate how dangerous it can be in our pregnant population to both the mother and the baby.
Good to know. Okay. All right. So now we've done our initial assessment. We found out she was hypertensive. What was your next steps?
We want to initiate transport, dealing with the scene safety thing, and obviously not knowing in 8 to 9 months delivery how soon baby's coming and things can progress. And it was her first pregnancy, so that's a little reassurance that maybe not going to come as quick, but we wanted to get things going. So we initiated transport. I rode in with the 5.5 unit, and both me and the 5.5 medic agreed quickly, like, let's get some mag on board. So we got a line established, and I believe looking through the notes, I think our transport time was, again, we're so close. Like, we were at press down town within 4 minutes, but we had 2 lines established and the mag drip going of the 2 milligrams since she was showing that she was preeclamptic with the 2 milligrams over 10 minutes. So we had that. In retro, I don't believe, looking through the chart or remembering if we actually got her on the monitor. But I just chalked that up as we just didn't have the time to do all that in that short time. But I would have liked to put the 4 lead on her at least. But I think we got a lot done in that short amount of time.
Yeah, definitely quick transport times from 4s. So you started the MAG, really short transport. So did you see any differences or improvements?
We didn't. Her pain really didn't change. And the vitally wise, she didn't change either. But I bet we saw 2 minutes of the drip go in before we arrived at press, and then they rushed us up to L&D right away. So we didn't really get too much time to reassess like any change.
Yeah. But aside from the pain and then the hypertension, was she exhibiting any other symptoms that led you down the preeclamptic route?
She wasn't. She didn't have blurred vision. She wasn't complaining of a headache. And that's kind of what I think we've been trained on to look for with that hypertension and those side effects. But no, besides the lower abdominal cramping, and she just looked uncomfortable. She kept trying to shift, and we said, you should lean on your left side. If you find that's comfortable, stay there. But she was just really squirmy and like trying to time if these are contractions, are they consistent, are we getting shorter? There really was no consistency with when the pain came, which again, a little confidence, like we're not an active going, it's happening now kind of thing. But no other signs really other than the discomfort, cramping, and then the blood pressure to go with it.
Good. Doc, ultimately our goal in treating the preeclampsia is try to help avoid the patient becoming eclamptic. Talk with us a little about the transition from preeclampsia to eclampsia and what are the risks associated with?
Yeah. So the transition to eclampsia is much more higher acuity. That's when the actual patient seizes due to the persistently high blood pressure. And that's what we're trying to avoid. So even though you didn't have time to get it on the monitor, you did the most appropriate life-saving intervention first, which is totally correct, getting that MAG on board. And we know it's a smooth muscle relaxant. It's going to help relax those blood vessels, which should help with blood pressure. But it also, in this case, especially if she was a little bit preterm, like maybe the 8-month side of it, of her gestation, it's also a uterotonic. It relaxes the uterus a little bit as well, which can also help delay a preterm delivery. They actually put people on drips for this in the hospital to delay having to do a C-section a little bit longer, to give that baby a little bit longer, prolong the gestation to a better delivery date. But if they start to seize and we're behind the 8 ball, or you get there and they're seizing, if you you still want to treat the seizure, so give Versed first, but recognize the pregnancy and then give MAG shortly after that. I think one of the easy places to miss this is that both preeclampsia and eclampsia can happen up to 6 weeks after delivery. And so thinking about it in your childbearing age females, like maybe, you got to take in some situational clues, but if you see a car seat or a bottle or a pacifier close by and you're at a call where a lady is seizing, that's an important question to ask if she's recently postpartum, because you still treat the seizure, but she may need some MAG in addition to that, because it's still a high mortality even after the baby's delivered. And the extremes of age are the most at risk for this, so very teenage pregnancies. And then also, it's weird to imagine a 35-year-old being like a older pregnancy, but advanced maternal age starts at after 35, and those ladies are at higher risk as well.
Good to know. So if we're assessing a pregnant patient, what would be our marker to decide that this is teeter around preeclampsia? You had mentioned earlier, we deal with more hypertension just as a society than we have before. So what's our cutoff point, if I should say, that we would start looking to treat it?
Yeah, so the technical cutoff point, and this is always best diagnosed in a clinic, right, where you can follow blood pressures over time, but if they're after 20 weeks gestation and their blood pressure is 140/90 at a certain point in time, that's where I'd start to be like, wow, that's kind of high. I don't know if this is just kind of where you live or if this is preeclampsia. I would start to explore like some of those secondary symptoms of it. Are you having headaches, blurry vision, right upper quadrant pain, peripheral edema? If I have a semi-high blood pressure, 140/90 plus one of those, I would go ahead and treat. Or in this case, she was severely high, and I would go ahead and treat that as well. So, because she's getting into severe ranges, and the last thing you want is for her to seize.
Right.
So.
Absolutely. Great job. As far as the turnover to the hospital, it sounds like you bypassed the ED. You guys went up to the L&D floor. Any turnover from the hospital? Anything changed? Patients stay the same?
Yeah, no, she stayed presenting the same way, and just the turnover to L&D, they gave us kudos for having MAG already hung, even though we haven't given very much at that point. But besides that, there was a smooth transition, and Dad was there. So
Good.
Dad got to be in the room with her, and right away got them connected.
And I don't think we got follow-up on this one to find out the health of the baby after it was born. We didn't get that. But as far as takeaways for new officers who encounter this situation, obviously we had the scene safety dynamic that you guys were able to navigate like pros. Any takeaways, nuggets that you would give to a new officer when they encounter a patient that's pregnant, severely hypertensive, anything you would do different or offer them?
I mean, I addressed it earlier a little bit. I would have liked to had got her on the monitor, just because we are introducing MAG. And so that was kind of a lesson learned for me. But also just the scene security thing of I closed the doors with lichens in there and I trusted lichens to, so like just trusting your team and needing to communicate with the engine and make sure that situation was handled before just jumping in the back and being like, we're just going to let this guy be mad out there and do his thing. So I think as officers, it's, do you have the ability to step back and look at the whole picture and not get tunnel visioned on, is this baby coming, and get sucked into that, to where I can let my driver get that initial stuff going and kind of manage everything else that's kind of going on. And I think that just takes time and reps and like having a good crew and being familiar with who's comfortable with what, and all those things come with time. But that's kind of like a lesson learned of looking back at that call.
And then pre-planning and practicing with your crew, had this been an imminent delivery, knowing who's going to take what role, and it is a basic skill. So
that's what I'm saying. Get in there, guys.
Deliver that baby. That's awesome. Well, I appreciate you, LT, for coming to talk to us about it. It's a very interesting case, and one that we regularly see, and a lot of people are just uncomfortable with pregnancy patients in general. So I think this was just a good reminder for everybody, but great job on the call.
Hey, thank you. Appreciate it.
All right. That's all we have for today. If anybody has any interesting cases they want to bring, reach out to the 7-8, hit up any of the EMS cadre, or you can use the SharePoint tab and come in and talk about your case. Until then, we'll see you next time. Thanks.